I've been on Doximity since it was a thing that you signed up for because everyone already had. Before that, I was an Epocrates guy, which if you're under 40, you've probably never heard of. The same founder built both. That's not a coincidence I think about often enough. During COVID, I had about 50,000 Medicare lives that I was responsible for, and I couldn't see in clinic unless they were sick enough to really risk it. Doximity is actually part of how I kept those patients alive without a waiting room. It's also part of how I eventually built part of my telehealth practice. So when I tell you that today's guests are not random vendor bookings, I mean it. They just launched something last week. It's called Desktop, and I've got the CTO who built it and the Chief Clinical Experience Officer who has to make sure that it actually helps doctors instead of getting in the way. Let's get into it.
DocPod presents Health with Dr. Hal.
Jey, would you mind walking me through what you guys shipped last week? What is Doximity Desktop? Why does it exist when the app already lives on every doctor's phone?
Yeah, it's a very good question. Once again, thanks for having me on the call here. So, Desktop is a new platform that we wanted to introduce because we've had this on mobile for a long time. We've had this on your browser for a long time. But ultimately, when you're in a clinical setting, that is not where you do majority of your work. And we wanted to be at that point of care where you're doing majority of that work. So being able to have a desktop app that's sitting in your dock that you can quickly launch up and be able to navigate that with the rest of the apps that you're using, that is critical. And that's where we wanted to be. So if you're doing a telemedicine visit like yourself, it's not always that you just want that to be the full screen where you're looking at the patient. You might be pulling up their charts on the side. You might be using our Ask product to look up drug information or, second checking some aspects of your work or looking up a clinical research material. All of that you can do directly within the app. You can move it to the side and have your EHR on the side or other details or other apps. That's really the power of the desktop app, being able to just live directly on your application, directly on your computer and be able to pull up all the time.
That's awesome. I mean, so you've had now, 150 health systems, including 8 out of the top 20 in the country that have already bought the clinical AI suite before desktop even existed, right? So what were they actually buying? Like walk me through Ask, Scribe, Dialer. I'm a clinician who's never touched any of them. And, full disclosure, I was on your medical advisory board last year. So I helped develop some of these, walk through some of these tools. And I think I was out of the 99% that wanted you guys to change the name from Doximity GPT to Ask. And that was, I think that was one of the best moves you guys made. Amit, do you want to walk me through a little bit of, how Ask, Scribe, Dialer, how that actually works? Like I'm a clinician that never touched them.
Yeah, I mean, it goes to a little bit of what Jey just mentioned in regards to going where these clinicians are. One of the other challenges that we face as a company, now having been around for 16 plus years, which is hard to believe, is reintroducing ourselves to folks who already used elements of the Doximity ecosystem, but may not have thought about how all of those elements could be leveraged together. So introducing this clinical AI suite was actually taking several of our most popular user products and presenting them in such a way that they're seamlessly integrated with one another. And just as importantly, they're seamlessly integrated with how clinicians do work, right? Like you mentioned, you started up a telemedicine component to your practice. I can say, even for myself as an emergency medicine physician back in the COVID days, under a threat of this once in a career externality, we had to learn how to practice medicine in net new ways. So we were picking up tools that existed kind of discreetly from one another on Doximity and on our own accord, stitching them together and utilizing them in order to kind of create net new workflows. With the clinical AI suite, we're doing some of that stitching work for what it's worth on behalf of our users. So we got a lot of feedback from Scribe users that, hey, while I'm actually doing my dictation and note review, it would be wonderful to be able to quickly launch Ask and either get some feedback on the note, ask clinical questions, so on and so forth. A lot of Dialer users, as you might imagine, could benefit greatly from having their encounter with their patient immediately transcribed and augmented, frankly, with Ask technology as well. So bringing all of these things together was just response to feedback that advisors like yourself gave us over the years, that the easier we can get to use, the closer to that actual point of care that we can be, the better it is for patient care.
Yeah, I mean, it's a tool that I use every single day. You know, I was in clinic today, and I normally on Mondays I'll have 30 patients in clinic, 8 brand new ones. So that's a 30 to 45-minute visit with me. And if I was focused on sitting there typing, or I wasn't able to have that face-to-face conversation with the patient, you lose that whole concierge feel. So it's really giving me back quite a bit of my day, the work day, and then I think it really improves the patient experience. And it's kind of cool when I walk in and the first thing I tell them is like, hey, I'm just going to click this button and it's going to, AI is going to take the note for us. And they're like, hey, you have to ask permission. But they always say yes. And it's kind of cool after I'm done, I show them the note and it's exactly how I would have written it. And it's, probably saved me about 15, 20 minutes per day, because I'm pretty OCD about how my notes have to look. And it does it all for me. So it's been a huge tool for many, many years for me now. Amit, you carry the clinical experience title. And, when health systems are evaluating something like this, what are they actually worried about? Where do tools like this fail doctors?
That's a great question, because the health system evaluation occurs in multiple layers, right? So at the topmost layer, you'll have folks that are first and foremost concerned with things like security, privacy, reliability. At like the system level, they're responsible for a lot of liability, frankly, if we're just being blunt about it. We can't have leakage of patient information. We can't have violation of laws like HIPAA, et cetera. No patient wants to provide their health and well-being to an institution that can't provide security, frankly, to very sensitive information. As you trickle down from like the leadership levels at institutions and you get to clinicians on the ground or clinicians at the front lines of care, they too are concerned about privacy and security. But frankly, a lot of us take that for granted, assuming that the institution has signed off. And we then focus on things like ease of use, integration into our workflows, and just not additional stuff to do, right? Like I can imagine, you just said you're seeing dozens of patients in a day, several of them new. If I'm doing an 8-hour shift in an ED, I can see anywhere from 25 to 35 patients on most days, all of them new. And if something has 4 additional clicks for me to accomplish, as trivial as that sounds, that math gets pretty heavy pretty quickly, right? I'm not nearly as good as you, it sounds, in terms of getting my notes done on time. So I'll take a lot of that work home. And I am a victim, if you will, of quote unquote pajama time. I'm at home, like logging in remotely, catching up on things. So anything that can prevent that additional time suck is a net positive. And we've gotten feedback over the years from users over things that you think would be so trivial, but wind up moving the needle in just these 15 or 20-minute increments as you described. And frankly, 15 or 20 minutes is the difference between beating rush hour or having dinner at home with your kids, or honestly taking a nap. Like whatever it is that's available to you with that additional time goes so far for those clinicians on the ground. So when we get health system evaluations, we definitely take that sandwich approach. We have a team of folks like Jey included amongst them, who will interface with the IT folks, interface with health system leadership, make sure that we can dot our I's, cross our T's, everything is secure, it passes the most stringent of protocols. And then we have folks like me who interface with clinicians on the front lines to teach them how to use the product, get their feedback for how to improve the product, and frankly, give them a sense of ownership as to their feedback being listened to, so that when folks like yourself, Hal, come in and advise us as to what to build next, there's nothing like that moment when you log into Doximity and you see that we actually built what you ask us to build, right? So Doximity Dialer, in terms of Doximity Legend, actually came out of one of our advisory boards. It was not a tool that was on our short-term product roadmap per se, but we had advisors come in, tell us, and make a lot of noise at our advisory board several years ago that they were having this very specific problem. And we listened to them. We built the tool, and we were in this opportune position then to significantly enhance the tool, of course, when COVID changed everything, and now on the other side of that, to really enhance it by integrating it with this clinical AI suite. So that feedback loop at all levels, it helps us a lot in terms of just gaining people's trust and letting them know that we're invested in making this successful, not only for leadership, but also for clinicians who are actually practicing the medicine.
Back
If
in
I
2020 with COVID, and we were looking for different tools, and back then so many different companies were coming out with different dialer style tools, and we paid it quite a bit of money to a couple of these companies where they promised the world. We brought them in. We had 750 clinicians, 800 clinicians across the system, and we paid for each one of these docs to have this specific dialer system set up, HIPAA compliant, so they could work from home, or if they were in clinic, they could call the patients to their homes. And what ended up happening was a bunch of us were using Doximity anyway, and we started showing leadership, hey, we have this free tool that we've been using for years. Why are we paying for this other tool that doesn't work as well? And what ended up happening is we paid all this money, and then 99% of the doctors use Doximity anyway. So you're absolutely right. If it's adding even just a little bit of friction for doctors, we just won't do it, because we have so much work to do already that anything that's going to add a little bit more friction is just not going to take off. Jay, you were going to say something?
I was going to say, that's so well entrenched in our motto. So, we say physicians first, and that could be interpreted in so many different ways. But one way I learned early on when I started this company 16 years ago was that reducing friction can be very small things. It could be as simple as a button. It could be simple as a modal popping up when it doesn't need to. But if you add those things up, it leads to such a better experience for the physician. And that's also being physicians first in terms of reducing friction, reducing the time that they need to spend to get from point A to point B within the app. And those things contribute to just better engagement for the physician and a better experience. And we focus on that very highly at every level of the company, and that's paid off for us.
I bring up you brought up pajama time, and that's something that my wife, when she gets home from work, she does 12-hour days, and she's primary care, sees 25 patients, has that whole pajama time. But then when she comes home, she pulls me off the computer and says, that's enough. It's too much time. And we have this tendency to do that as doctors. So giving back that time to doctors, I think, is a real mission. That's something I admired about what Jeff, your founder CEO. He's not a doctor, but he understands what's important, right? What time is important to give back to doctors, and that the advisory board stuff that you guys do. It's not 12 guys in a room making decisions for the 3-4 million docs that you have on your platform. You guys fill up thousands of docs in a room, and then the breakout sessions are hundreds of docs at a time. So that's it's pretty incredible that you guys are doing that on your own dime, and then actually using the information that you get back, the feedback that you get back from us, to build it out. What actually building something for doctors using their input. I mean, it seems like a no-brainer, but in this day and age, it's a very novel concept, because you guys see all the tools that are out there that are being built, by non-clinicians for clinicians, and they're solving problems that don't exist, or they don't, because they don't have boots on the ground. It's almost impossible to tell. I do the same thing, day to day, when we're looking at different things for physician estate. If it doesn't solve the end user, or if the end user is not involved to begin it from the beginning, it's going to be a fail usually.
Yeah.
I did want to shift over to a little bit on desktop, and I'm going to count this as an exclusive, because I know you guys are still slowly rolling this out.
That's right.
But desktop, I do a lot of my charting at a desk, not on a phone. What changes for someone like me with this picture in picture during a telehealth visit? Walk me through that flow, and either one of you could take that.
Yeah, sure. I'll give it a start. Amit, feel free to jump in. So the idea behind picture-in-picture is it exists on a lot of other platforms you've seen, from Google Meet to Zoom, where you can kind of minimize and get this call itself into a small part of the screen while you focus on other literature that you might be reading. And that's what we were trying to achieve here with the desktop applications picture-in-picture. So you start a call. You can have that also be integrating with Scribe, so it's actually doing a recording of the call as well. And that can just minimize to the right of the screen or to the left. And then you can use the other features within Doximity. So you can go send a fax if you wanted to, or read on the news feed, or ask a clinical question, or look up a drug monograph and check interactions as you're having those discussions with the patient. That's the beauty of it. So you get to kind of minimize it instead of it being the full screen view.
Awesome.
Yeah, and you know
Um,
how like when you're in a room with a patient, you're often doing that kind of multitasking. We, in the early days of Dialer, heard from clinicians, just like other humans who are kind of learning this new teleconference reality in real time, that they found it awkward. They didn't know what to do if they had to quickly reference something in somebody's chart, or they had to look up something if they're writing a script. Or, I mean, in my case, I need to read somebody's echo results so I have something intelligent to contribute to the interaction that I'm having with them when it's a virtual care interaction. The ability to do that more seamlessly and more naturally, I think goes a long way just in terms of unlocking some of the benefit from remote care, right? Even in critical care specialties and surgical specialties, when we look at our own usage rates, I'll admit folks like Jay and myself and some of the other clinical folks at Doximity will take bets as to whether or not we think something's going to be popular with one group versus another. And I was genuinely surprised when we looked at the data for Dialer and Scribe, because there were a lot of specialties using it that frankly I wouldn't have presumed that would be using virtual care as much, or integrating
Hmm.
hybrid care, if you will, into their clinical practice. And I think with desktop and things like PIP and being able to do all of these things simultaneously, it just makes the Doximity version of that experience a touch more natural, right? And if you're going through a clinical encounter for provider and patient alike, that natural bit, I think, matters a lot. You know, like I'll joke back in the later days or maybe the middle days of the COVID experience, there was a Becker's article that came out, and don't quote me on the number, but it was like, here are the 280 plus telehealth companies you should know about, right? Just to give you an idea. It sounds like you had an experience with that where everyone and their mother could make a wrapper of somebody else's technology and come to you and charge you some money for it. But it's like thoughtful little additions like what Jay just alluded to that reflect the fact that we actually have clinician users telling us what to do, right? Like these are the people who are ultimately going to be using the software. And it's very important to us that we don't do things to these people. We actually build things for them. And like that sounds like it's a nuanced difference, but it's actually pretty significant. If something as simple as being able to multitask in a way that makes your patient feel paid attention to, you're not going to figure out that little bit of feature addition to your software without speaking to the actual users. So I think it's another example, as Jay mentioned, of like simple things actually having pretty significant impact.
yeah. Speaking of wrappers and AI, I tell my clinicians all the time that I want them using clinical AI tools. I don't want them using, what the layperson is going to be going out there and Google's great. ChatGPT is great. One of the things that we had brought up during our MAB was that you guys were calling Doximity Ask. Now it's called Doximity Ask, but you were calling it Doximity GPT, and all of us were like, no, that doesn't sound clinical at all. Want us to sort of step away from that. But then even some of the folks that are doing this in the current field who are using clinical sounding names, there was an article that came out in Nature that compared some of the clinical tools, and they were worse off than the stuff that's available to the layperson. And I come from a family where my youngest brother is a machine learning engineer, so he makes fun of us that he came up with AI, or they've been working on AI for 10 years before AI was AI. And what he taught me was that AI is very garbage in, garbage out. So it's whatever you put into it is what the output is going to look like. And what I'm finding with these LLMs that are available to the general public is they're pulling from everywhere. They're pulling from the podcast of a guy that did a couple of YouTube videos and decided he was an expert in the field, and now he's talking about peptides, or someone who's not licensed to practice medicine giving medical advice out there, or med spa blog posts that are really stretching the science on some of the stuff that's out there, and that's what it's pulling from. I've seen Doximity Ask really, first of all, the 3 seconds response time, and then it pulls from peer-reviewed journal articles. It pulls from journals that I input in there, and I say I wanted to pull only specifically from this one. So where does that evidence base actually come from? How do you keep it current? And how is that? It's really a differentiating thing for you guys.
For sure. Let me talk about some parts of it. Amit, maybe you can jump into some of the guidelines and the peer check aspect. So even if you look at peer reviewed literature, there's a lot that shouldn't be used for a medical model like that. So we've taken the time, and with their acquisition of Pathway, to go through all of the peer reviewed literature and make sure we're filtering it down to ones that is going to be actually applicable and make the model better. And that's a time consuming process. There is a lot of literature out there, and we want to make sure it's filtered down to things that's going to be helpful to humans and to physicians versus things that are a little bit more broad but are still peer reviewed literature. So that's one step of it. The other is also looking at drug monograph data, which also plays a big part in being able to make sure the model has a good strong harness around its fundamentals. So that's the second part of it that we tend to focus quite a bit on. Um, and of course, we don't want to be going and searching, anywhere on the web. I think that can lead to a lot of false positives. But even within this smaller literature of peer-reviewed articles that we filtered down, we have to make sure we're staying up to date on that information. So if a new content comes up that contradicts another one, how are we going to represent that within our knowledge graph so it's able to make sure it can reason about both of them instead of ignoring one or the other? Or if there's an update or a particular article's been recalled for whatever reason, are we able to update that within hours? And that's kind of the goal that we have, is to make sure we can update that within hours or even less in most cases, instead of waiting days, weeks, or months to be able to do that. But I think where the real power of this for us and making our model considerably better comes from, working with guidelines, of course, and our peer check product. And I think Amit's been more on the ground with our peer check team, so he can probably fill in a little bit more detail there.
Yeah, I mean, Hal, I don't want to age you, but I imagine you and I are similar age. So we trained in the like WebMD, Dr. Google generation, right? So we'd have folks who would look stuff up and they'd come in with all sorts of opinions, if not their own diagnosis and like their requested workup and treatment plan. And don't get me wrong, I'm actually a big advocate for patients doing their own research, but then coming to the table to actually have a informed conversation around what should probably happen next
I
to
call
them.
it I
What we're
call it doing their
seeing
own reading.
with the more general,
I call it doing their
yes,
own
that's
reading, not
fair.
their own
That's actually
research, because
probably a,
explaining what research actually means.
yep.
We haven't done research since medical school or since residency, if you really think about what research looks like. So it is doing their own reading, and I agree with you there.
That's fair. Actually, I'm going to take that from you and start using that because I do think that's more accurate. But they would come in having read something or another that would influence their thinking. And I imagine this comes up in your practice. It certainly comes up in my own with LLMs and AI now. What I find is those folks are doing a different version of reading, if you will, but they're coming in with a good bit more conviction, right? Like they've been convinced now that X, Y, and Z is the case. And to the earlier point about some rando talking about peptides or what have you being part of that evidence base, that can go a very long way to complicating the interaction with clinicians. So for all of the reasons that Jay mentioned, we kind of restrict, if you will, the aperture of our tool to be high quality, high impact, reviewed information. But even that is just a step in the right direction. So clinicians, when we surveyed them en masse, so several thousand respondents, when we asked them not just about the upside of AI technology, but if there was anything that was their primary concern, 71% responded that accuracy and reliability was an issue, right? So part of my job is reminding Jay and everyone at Doximity, doctors are people too, right? Like we use AI tools in other ways, and everyone's seen the picture with the eyes all sideways, and everyone's gotten some kind of output that doesn't make sense. And a lot of us are scared that part of an clinical version of that would be also similarly erroneous. So we took a look at our own data in Doximity Ask and noted that of the cited authors of the references that the AI was actually synthesizing the output of, the vast, vast majority of them actually were on Doximity. So what started off as an experiment late last year that spilled into the early part of this calendar year, we invited those folks to come in and say, hey, can you take a look? First off, congratulations. Your work has been leveraged by this exciting new technology. There are clinicians that are out there that are using it in real time. That's a point of pride for any scientist that's kind of contributed to the medical knowledge base. But
Hmm.
the vast majority of folks were willing to engage, right? So going back to taking bets, I was a conservative on this one. I thought we'd get a couple hundred folks in the door. They'd give us a few hours of their time. Maybe we'd get a few thousand topics reviewed, and that would be great, to be honest. We get now in just a few months here have gotten about 11,000 domain experts in that have reviewed north of 30,000
Wow.
clinical like snippets, right? So very, very quickly, we've created a proprietary corpus, if you will. It's Gen AI based on the medical corpus that has now been reviewed by human domain experts that can then
Hmm.
be leveraged to go back and given to Jay and team to make the underlying technology that much smarter. So we're really, really excited about the potential there. And I will say, anyone who practices medicine, you're at kind of the forefront of men's health. You know that there wasn't a paper last Tuesday that answered all the questions that exist about men's health. Like the actual corpus itself has its own limitations. So we are currently rolling out a kind of glue, if you will, from my perspective, where we permit those experts to not only come in and participate in peer check, but actually go so far as to submit expert commentary on top of that, which we call how I treat, right? So is gaps, or there are gaps rather, in the published evidence that can be filled by folks who are actually practicing medicine at the cutting edge
Hmm.
of medicine. So we can equal parts have cutting edge technology that helps with that synthesis and search and research or reading, as you said, but then actually bring the humans to the party and fill in any gaps that exist in the corpus. So I was wrong on that bet. I was happily wrong, I would say, insofar as the momentum that we've been able to unlock in just a few months here. So we're leaning in as an organization because the throw weight of Doximity is not only the process that we described, it's not only the tech that Jay and team have built over the years, it's the people. Like we have several million clinicians now who utilize Doximity for all sorts of purposes, many of whom have raised their hand and said, hey, we would like to contribute, right? Like most doctors, I'm sure in your practice that you run into who refer to you, et cetera, they want to know what their place is as kind of the evolution of medicine is happening in real time. So we're pretty proud to be an avenue through which those folks can actually participate and contribute to how this changes how we all practice.
Yeah,
And I
I
find,
would
you know, the
say
best
that.
clinicians generally are going to be the ones that want to advance that culture of learning is something that it's ingrained in all of us. No matter how much we try to hide the inner nerd, it's there, and you'll continue to see it. I think, especially. I find it in my own system. You know, I do didactic calls every week, and the ones that volunteer to do the presentations generally are the best clinicians in the system. And when they're teaching, you can see that it's really a vocation for them. It's not a 9 to 5. It's not something that, you know, they go home and they're not thinking about work. It's they're reading. They're constantly. I get text messages at random times a day, like, "Have you seen this article or that article?" We have an entire group chat just called Journal Club because we're
That's really
constantly
cool.
sharing different ideas there. So what you're building out with, and one thing I did want to say with some of these LLMs is how confidently wrong they are. And
Yep.
that's what's scary to doctors, is because we
Mhm.
have patients who come in who are very confident about this confidently wrong tool that they're using. And we see that in the wellness space all the time, all these grifters that, you know, they'll say something with an absolute. And I'm like, this in healthcare, it's just not like that. We have guidelines, but they're just that, they're guidelines. And when I do my teaching, I use, you know, American Urological Association guidelines. I use the Endocrine Society guidelines. I use the internal medicine guidelines, but I then will tailor it to the patient in front of me. And I tell my patients that all the time, that you know, guidelines are not for, they're for learning. And then you treat
Mhm.
the patient in front of you. And that's what I think, what you guys are starting to build with this whole peer check.
Yeah, I was just going to add on that, there's two sides to these tools. One is the research oriented, where, you're sitting down at your computer. You might be okay taking a few minutes for a response to come through. And then there is, how you actually treat the patients. And that's where, speed and being able to iterate quickly on your prompts and be able to get the answers that you need really do matter. With a lot of these tools, you will see things like, instant and thinking mode. And, we have something similar there. And with the instant mode, we've seen physicians, work with patients and how little time they actually have between interactions going from one patient to another. This is why, our goal was to try to reduce the time it takes for the answer to be generated drastically. Because with a lot of tools, it might take 30 seconds, 1 minute for the answer to generate, but you don't really have that in an interaction with the patient. You need it to be quick, similar to a Google search. And that's kind of our intent with some of these instant tools is to get that response to be as quick as possible. So you can, once again, going back to, treating the patient instead of fumbling with the tool or saying, oh, give me 30 seconds. I'll give you an answer once the AI responds.
You know, I wonder how many of these tools are being used in during rounds or like morning rounds or, in residency rounds. Because even when we were coming up, I noticed the medical students were just faster and faster and faster. And I can't imagine with these tools in their hands now, how much incredibly faster they are. Like when we had, the teaching sessions during residency, and they would tell us the topic that we had to work on, and it was coming out of specific study tools that we had to go through, and we had to read the entire thing so that we could possibly figure out an answer during those sessions. Now it's 2 seconds away from your fingertips. I wonder, does that make them? That makes them faster? Does it make them as smart as I guess some of our generation was? It's just it's something I think about off the top of my head. I don't know. Pivoting to something else, as somebody who sits on multiple private, public, federal advisory committees, verification is really important to me. It's something that I go through on a pretty regular basis. Background checks, feel like colonoscopy. Sometimes they could take months at a time to get verified and backgrounded on some of these committees. Doximity built its name really through a network of confirmed, verified physicians, right? Not just anybody with an email address. That's important to me. When I log on to Doximity, when I'm conversing with someone or someone's trying to connect with me, I know they're a real doctor. They're they have a medical license. Most of the time, they're in the United States, and you guys built your name on that. So walk me through how that verification actually works, why you build it, and why you built it that way from the start.
Yeah, so when we started the company, there were other medical networks at the time. Some of them were unverified. You can kind of create an account very easily. For us, there was huge value in having this network of physicians that know each other, went to med school with, were residents together, that can get that guarantee that this person is who they say they are, and it's not someone else posing as that person. And that's why we built a very in-depth verification flow. So this is similar to what you might go through if you sign up for a bank account, where it's asking you verification questions. But we do take it a step further as well. We will ask for your medical ID to be able to verify you. Of course, if you are at an institution and we have an institution partnership, we can do that at a larger scale to help roll that out. But that was extremely important. And the feedback we got early on was that network knowing these physicians are verified made people feel a lot more comfortable having discussions and messaging each other and feeling like this platform was for them. It wasn't just for anyone else that is not a trained medical professional. So that's stuck with us to this day. We still go through the same process for verifications, and I think it gives a lot of trust to the network and the people that you can find on that network.
85%, I think, of US
That's right.
doctors are
Mhm.
already on Doximity. So at that kind of penetration, what's left to build? And I think I know the answer to that. But what does the next 2 years tell me on this platform look like to both of you? And Jay, you've been with the company since day one.
Not day one, but a couple of months after.
Okay.
Yeah.
So what are the next 2 years for the longest standing company in the space look like?
Yeah, so yes, we have over 85% of physicians on the platform, but it's not just about physicians. It's also about NPs, NPAs, and PharmDs. So we are continuing to grow into that healthcare space. So you can, depending on your role, depending on your specialty, you can get that full end-to-end experience all within the Doximity platform. And that means, going beyond MDs as well, and focusing on some of the other areas within healthcare. So we're continuing to operate there. But the biggest focus right now is with some of our AI, clinical AI suite. There is a huge amount of time savings that we weren't able to ever achieve before the AI era, to give physicians time back. And that's possible with the Ask product. It's possible with Scribe, but it does take time to teach physicians how to use these tools and how to use it effectively, and how to reason around the mistakes it can make and when to use it in which setting. And that's a learning experience that we want to go with the physicians towards. So I think there is still a huge growth opportunity here with AI. I think we're just getting started here with our clinical AI suite, and I expect there to be more developments within that space over the coming years.
What about yourself, Amit?
Yeah, so I mean, the stat that Jay didn't mention amongst kind of a litany of impressive stats is that we actually have north of 90% of graduating medical students that utilize Doximity before they ever even hit the wards as a kind of MD to their own right? Like Residency Navigator is one of our most popular tools that manages a pretty critical career transition for clinicians. And I think that provides us a tremendous opportunity to actually get involved early on in folks' careers in a way that, again, is dictated by their feedback, so that they can actually trust some of the tools that we create these next 2 years and beyond, and leverage those tools throughout their career. So Jay and I are getting together actually to work on something called study mode, right? You know as well as I do, clinicians are constantly studying, whether it be for your USMLEs, for your research, which I just did a couple months back, or frankly, just to stay fresh, right? Like I pay other organizations money for the honor of leveraging their Q banks to study and stay fresh, like on a day-to-day basis. So we're bringing that kind of tech powered by AI and diffusing it throughout the entire Doximity experience. Like in a future state, we would love for folks to not only be able to use Doximity Ask, but have that same kind of conversational exchange with other elements or other tools of our toolkit, so as to become expert as to how to leverage this kind of technology and be better clinicians, right? Like you mentioned it a couple minutes ago, we talk about this at the institutions that I work at clinically. How can we gauge whether or not this student is actually on top of what it is that we're asking them, or are they just messenger pigeoning the output of some tool that they're leveraging on their now desktop, thanks to Jay and team? And the honest answer is we want to teach these folks how to be good stewards of this technology in service of the practice of medicine, not just to get through rounds, right? You're familiar with that pressure. I'm familiar with that pressure. We now probably apply that pressure to others, frankly, in terms of when we teach students. But that's not the point. The point is to actually integrate that knowledge in a way that's useful. And now what's net new is integrating knowledge of technology in a way that's actually useful and augments your capabilities as a clinician, as opposed to like outsourcing what otherwise would be critical clinical thinking. So we have a couple aces up our sleeves that we're going to be releasing over the course of the remainder of this year and into that 2-year period that we're genuinely excited about, because we think throughout the duration of someone's career, we can teach them how to leverage this kind of technology in ways that up levels their ability to practice medicine. And honestly, that's the whole point.
I mean, knowing Jeff, I don't doubt he's got quite a few aces up his sleeve with this team that he's assembled. He's already done it, a couple of times, surprised me over the last 2 decades. So I'm sure he's going to do it again. I've watched this company sort of really reach out to a bunch of different hospital systems, and I started using it in med school and everything else. But I want to ask about the solo guy, because that's what's in my space. There's a lot of that, the wellness longevity, if you'll call it. I don't like that word as much as preventative care, but a solo practice doctor, right, in a small market, or a guy running a clinic with a skeleton crew, he's going to hear all this about Doximity and assume it's built for the bigger hospital systems, not really for them. Is that true? And what does this mean for the independent guy?
Yeah, so that's not true. It's meant for the individual physician, and we've always been that way. We didn't start partnering with hospitals till much later in the company's history. So when we think about the features we build, we think about how can this enable and empower the individual physicians? What can it bring into their own toolbox? One of the features we shipped recently was e-prescribe, so being able to do prescription very easily directly from the Doximity platform instead of having to sign into another platform that you might have to pay a monthly fee for or call into the pharmacy and wait for hours. So every one of our features is accessible to every physician, whether they're part of a hospital system or not. What we do with hospital systems is we will do an enterprise BAA. We might do some additional functionality that they might need for integrations into other systems. So those all come separate, but all of those features that are seen by enterprise is available to individual physicians on day one. As soon as they sign up and get verified, they have access to that full suite. So this includes our Ask, this includes Scribe, this includes ePrescribe, includes a free fax line that you can be using. And I know it's kind of a joke still to think about fax, but it's still heavily used by a lot of physicians. So all of that is freely accessible to physicians. It always has been, always will be.
Yeah, you guys are the only reason I still have a fax number. So I don't own a fax, but so many of these hospital systems require it. And having that on my phone, where my staff is always like, they want a fax number. A pharmacy that's, been around forever and supposedly is updated and everything else, they want to fax you something, or the hospital system to send over records. And I'm like, well, use my virtual fax. That's what I got through Doximity. So it's, I still have a fax number. So I appreciate that. I've watched this company go from a social media app that I used to check a colleague's contact info on to something that helped me carry 50,000 patients through a pandemic without a waiting room. Desktop is a small sounding word, but actually a pretty big shift. It's taking AI out of the phone and putting it where the real work happens, at the desk, mid chart, mid visit. Jey, Amit, thank you so much for the time.